salon, and before I introduce the speakers, is really to have a small gathering for everyone to be able to come together and really learn from one another in terms of sharing lessons learned. And when I looked at this in the original intent of the salon, this was a product in the 18th century, early 18th century, and really an idea for people to come together and have an intellectual discourse. And for us, it's really around this issue of how do we increase screening of perinatal mental health disorders. So we have two wonderful speakers from two different parts of the world sharing their lessons learned, but we really want this to be able to have this as a discussion and learning from everyone, which is one, wonderful part of Marseille International to have this international group together. So I'm going to introduce first both speakers, and then I'll kind of have them take over. So Mijke Lambregtse Berg is a perinatal psychiatrist, a child and adolescent psychiatrist, and an infant mental health specialist at Erasmus Medical Center in the Netherlands. She does a lot of wonderful research in the area of perinatal psychiatry and offspring development. And then Bina also just joined us as part of our steering committee as a researcher and assistant professor in the School of Social Work at Ilan University in Israel, and a psychotherapist working with women in the perinatal period. Her research focuses on the impact of perinatal mental health treatment, utilization, rehabilitation, and recovery. So we'll have both speakers go for about 10 minutes each, and then we really kind of just want to open this up for questions and lessons learned from that. So without further ado, Mijke, please.
I'll try to share my screen now. Let's see. Oh no, this is not working, I think.
We just saw it, Mijke. We just saw your slides, so I think you might be showing. Yeah.
Oh, let's see this one. Yeah, but now you see the total screen, I guess.
There you go. Now we see your slides. Perfect.
Yeah, can you see full screen now?
Perfect. Yep, we see full screen of your slides.
Okay, hi all. It's my pleasure to share some of my experiences regarding screening for perinatal mental health problems and other vulnerabilities during pregnancy in the Netherlands. I'm working at the Department of Perinatal Psychiatry at Erasmus Medical Center in Rotterdam, the second largest city in the Netherlands. And at our specialized department, we focus on diagnosis, advice, and treatment of perinatal psychiatric disorders. And we have outpatient clinic, day treatment clinic, mother-baby unit. And also we closely collaborate with our colleagues from the obstetrics and gynecology, the neonatology, and the clinical pharmacology departments. My work about screening started more than 10 years ago in close collaboration with my colleague obstetricians and pediatricians. And it was based on national and international reports on perinatal mortality. Although healthcare in the Netherlands is of high standard, perinatal mortality was relatively high compared with other highly developed countries. In-depth studies showed that this perinatal mortality was associated with structural inequalities on a population level, in which women with lower socioeconomic status, different ethnic backgrounds, and women from deprived areas turned out to be at particular risk for these adverse outcomes. But also individual factors show to be associated with adverse outcomes for both mother and child. of which the influence of the broader spectrum of psychiatric disorders, so not only depression and anxiety, but also psychosis, bipolar disorder, autism, and personality disorders, psychosocial problems, and substance use. Together we shortened as PPS, were not routinely addressed in obstetric care in the Netherlands. However, it's important to routinely address these individual factors altogether, as they are associated with adverse maternal outcomes, such as unhealthy behavior, with withdrawal from psychiatric and obstetric care, the occurrence or persistence of psychiatric problems in the postpartum period, and suicide, which is, as you might know, the leading cause of maternal mortality. And also, these vulnerability factors are associated to what we call the Big Four, consisting of congenital malformation, preterm birth, small for gestational age, and low EPGAR score at birth. And together, these Big Four explain 85% of perinatal mortality in the Netherlands. In addition, one of our studies showed that also the accumulation of different risk factors is of importance, in which we found a 58-gram lower birth weight per PPS risk factor. On the other hand, in the Netherlands, there is a lot of care targeting at mental health disorders, social problems, and substance use in the peripartum period. This is, for example, an overview of all the programs we have in Rotterdam. However, in clinical practice, most of the women for whom this care is indicated do not actually receive this care. And as almost all women in the Netherlands visit a midwife or gynecologist, the ideal setting to discuss such PPS risk factors would be in obstetric care. But also from clinical practice and research, we learned that women, on the one hand, are hesitant to discuss their vulnerabilities because of shame, stigma, and fear of being judged as a parent. And on the other hand, obstetric care workers are hesitant to ask for these factors because they feel a burden to discuss these sensitive topics. They often feel not competent or well equipped when a woman tells about alarming signals, such as suicidal ideation or domestic violence. And also, lack of time is an important reason not to ask for these risk factors. Therefore, in a multidisciplinary team spread out all over the Netherlands, we developed an easy-to-administer instrument for the detection of psychiatric and psychosocial problems and substance use in obstetric care. The instrument is a web-based online questionnaire that women complete at home around their first booking visit. It's adaptive in a way that if women have particular risk factors, additional, more in-depth questions will be asked according to a predefined algorithm. And a big advantage of the instrument is that a woman with certain risk factors will get a direct and tailored advice for possible support in their own neighborhood. And if a woman gives consent, the results of the screening will be sent to the obstetric care provider as well, which allows for a shared decision-making process and, if necessary, a concrete and targeted referral. And finally, the instrument can be easily adapted for local care according to predefined selection criteria. As you can see in this picture, in which the psychiatric risk factors, the psychosocial risk factors, and substance use are subdivided, you can see that every risk factor leads to a specific and concrete alert or advice. And here you can see some recent results of the routine screening. The instrument is currently implemented in 30 to 40% of obstetric care settings in the Netherlands. And when offered in routine care, 75 to 95% of women is willing to complete the instrument. 24% of women has at least one risk factor, of which psychiatric problems are most prevalent, followed by psychosocial problems and substance use. And 10% of women has at least one risk factor. Altogether, with this instrument, we have significantly contributed to discussing and addressing very sensitive topics in obstetric care, which ultimately lead to less stigma and more concrete and targeted care for vulnerable women. And we are currently in the process of linking the outcomes of the questionnaire to help-seeking behavior and whether this leads to better maternal and child outcomes indeed. And I would like to end with a statement for the discussion that will follow. And this is in order to increase and improve screening of perinatal mental health disorders, we should also include other vulnerability factors as they are closely related and need an integrated care approach to decrease both maternal and child adverse outcomes. So this is the end of my presentation.
Thank you so much, Mijke. That was really great to give an overview, and how impressive is that? Rena, please.
Yes, I'm always impressed at all the work that Mijke is doing and has done there. So yeah. Okay, so let me try sharing mine. I cannot check. One second. It says that I'm sharing my screen, but I don't see anything. Do you see anything?
We are seeing your entire desktop. So
yeah,
you may need to
that's
go in.
like weird. That is really weird.
There we go.
Now you see?
Yes, yes. Now we see your slides. Perfect.
You see my slides in a slide presentation?
Yes, full slides.
Good. Okay. So hi everyone. So my name is Rena Bina, and I'm a clinical social worker located in Israel. I'm also a professor at Bar-Ilan University, and also assistant professor, and also a psychotherapist. I work at a clinic. So what I'm going to present today is when I was thinking about how to increase screening for perinatal mental health disorders, and this is a question I've been tackling for, I don't know, 20 years maybe. And I did various studies on it. So I want to give like lessons learned from the studies that we did here in Israel, and also from our experience with screening, because we have, since 2013, we have a mandated universal postpartum depression screening for all women. So some lessons learned, that if people want to increase screening or implement screening, I think these lessons will help them, hopefully. So I came up from my studies, and together with some colleagues, that we found that there are three major entities that impact the screening process: the healthcare systems, the services themselves, the health and mental health care service providers, and the women who experience postpartum depression or perinatal mental health issues. So I'll talk about each of these entities, their barriers and facilitators to like optimal screening, I call it. So let's talk about the healthcare systems first of all. I think that the main barrier with the healthcare system is that there's not enough understanding there, first of all, of the importance, but also of how to implement an optimal screening program for perinatal mental health disorders. And what I could offer here, and it's very short and there's a lot of more work to do, but, just to give like the gist of it. So I think there should be 4 questions asked if you want to plan and implement a screening program. First of all, the purpose. What is the purpose of the screening program? Why do we want to do the screening program? Do we want to only refer? Do we want to also do a short intervention? What type of intervention? What do we want to do? So we have to think of the purpose. We have to think of the population. Do we want to target pregnant women, postpartum women, the entire perinatal period? And then think about the plan. When do we want to do it? 4 weeks postpartum, 2 months postpartum, pregnancy, when? Where do we want to do it? Do we want to do it in person? And if we do it in person, then where? In obstetric clinics, in pediatricians' clinics? Like, where do we want to do it? Or do we maybe want to do it online or web-based? Who is going to do the screening? Is it going to be OBGYNs? Is it going to be midwives? Is it going to be public health nurses? Who's going to do the screening, and how is the screening going to be done? Is it going to be universal in the whole country, local in a specific place? What elements should the program include? Should it include also an intervention? Should it include assessing risk factors also? Should it include only referring? And what screening tool should we use? And what does it screen for? We should also know what the screening tool that we choose, what it screens for. And of course, we need a referral system, because if we don't want to screen just to screen. Okay, we want to screen in order to help women get help. So we have to have a good referral system. So I just want to give an example of answering these plan questions in the Israeli system. So in the Israeli system, we have, as I said, a universal postpartum depression screening procedure. We do it at 4 to 8 weeks postpartum. We screen all women 4 to 8 weeks postpartum, and it's done in mother and child clinics in Israel. All the healthy care visits and immunizations are given in these mother and child clinics that women or families come to there from with babies from the age of newborn until 6 years old. So all women come across these clinics, and they're screened over there. And those who do the screening are the public health nurses, and it's done using the EPDS. Now, the screening program in Israel includes 3 elements. First of all, the screening itself. Second of all, an intervention. So women who screen between 10 and 13 on the EPDS have 2 to 3 sessions with the public health nurse who did the screening to see how they're feeling and to help them out. And women who screen 13 and above are referred to a mental health specialist. And also women who screen 10 to 13, if the nurses feel that they have to be referred on, so they are referred on, and we have a good referral system. That's the healthcare system. The next group that we have to think about is the women themselves who are experiencing postpartum depression. And over there, when we're looking at barriers to optimal screening in terms of the women's perspective, so what we found in our studies, that not all women comply with the screening. Now, there are very minimal studies done on that in a couple of countries, and we did in Israel. We did 2 studies in Israel as well, and we found that not all women comply, and soon I'll give you even the numbers. And we also have low seeking help rates. So even women who do comply and are referred on do not continue on with a referral. So I think a major question is, are the screening programs acceptable to women? And I think they have to be implemented in a way that is acceptable to women. And I'll give a couple of findings that we found. How could we make these screening programs more acceptable to women? Because if it's acceptable, that's essential for their compliance. So first of all, we asked women, will you truthfully reveal your emotional state to the screener? Because if we're saying if women score 10 and above and we're going to do something at 13 and above, we have to see that they're answering this honestly and they're getting these numbers. So we found that only 62.5, which is not a small number, but these 62.5% of women said that they'll truly reveal their emotions to the screener. But around 38% of women are saying that they're not going to, probably not, or definitely will not reveal their emotional state. So we're screening, but almost 40% of women aren't answering honestly. So we have to see how we help them answer honestly. And here are a couple of things that we found that could help women answer more honestly. So first of all, we checked acceptability rates when meeting with the same nurse versus meeting with different nurses. Again, the nurses are the ones who do the screening. And we found that a higher acceptability among women who meet with the same nurse regularly, and not each time with a different nurse. When we checked other factors associated with acceptability, so we found that, first of all, perceived benefit. Women who perceived that the screening will benefit them were more likely to answer honestly. It was more acceptable to them. And I think this is important for the screeners to know, to say, to explain what's the benefit? What is the benefit of being screened? The second thing we found was the perceived quality of relationship with the screener. So again, it taps on the same thing of having the same nurse. So we found that women who had this same nurse for a long time, and they were followed up not only by screening, but they had a good relationship because it was based on other things, that maybe during pregnancy they met her already, and then when it came time to screen, they already knew the nurse, they had a good relationship, so they answered more honestly. So this is another thing to think about. How do we have this long-lasting relationship, and that this person who has this long-lasting relationship will be the screener? Perceived susceptibility. So women with risk factors, women who perceive themselves as susceptible to postpartum depression were more likely to find it acceptable. And we also found that older women who had less children also found the screening more acceptable to them. So these are points to consider when we want to have implement an optimal screening program. Now, the last point is looking at the health and mental health care service providers. And their perspective, this was another study that we did, that we asked the screeners themselves, how prepared do you feel for doing this screening? And we looked at factors that were associated with it. So many of the providers said, we have an overload of tasks. We don't have time to do this. Now, don't forget that if we're talking about, let's say, nurses, okay, so the nurses have other more technical things that they have to do. And usually we'll do technical things before having this emotional conversation, because screening is not only giving out the EPDS, it's having a conversation about how are you feeling today? Okay, it's an emotional conversation. And then the second thing that the nurses said when we asked them about barriers, they said about a skill barrier. They said they're not trained to have emotional conversation skills. Okay, I mean, some people have it more than the others, but they're not trained for how to do it in a good way. And a lot of them are afraid that a woman will answer positive on number 10 on the EPDS. In the past week, you have thoughts of harming yourself. And then they're afraid if someone will say, oh, yes, or maybe, or whatever, then what am I going to do with this? So they felt that they need more skills in this. And this taps into the training, how much the training is important here. And another thing is a population barrier, because they said that it was difficult for them to have an emotional conversation with women from a different background than theirs. So they said it's easier for them, let's say, to weigh the child or giving them baby or giving them immunization, but to have an emotional conversation, it's more difficult for them. So again, this is important for the training to understand how we should train these screeners. Now, a couple of more correlates of perceived preparedness. So what other things did we find that raised the likelihood of the screeners to feel prepared to carry out the screening? So first of all, attitudes. So screeners who had more positive attitudes towards treating women with postpartum depression, whatever, they were more likely to feel prepared to do the screening. Those who had more knowledge about postpartum depression, those who felt more competent, and those who had more training, whether in-house within these clinics or in academia. A lot of the nurses who were the screeners said that in academia, they had a couple of courses on this, and that gave them confidence and feeling that they're competent to do that. screeners who felt that their colleagues are prepared to do this screening also felt more prepared, and also those who felt that their supervisor was supportive of them, and also their organization, because feeling that their organization is supporting us means they're going to give me more time to do this screening, because the screening takes time, will give me a better space to do this screening. So these are other important factors to consider. So I think to sum up, I think that if we're answering the question of how to increase screening for perinatal mental health issues, I think we really have to look at the healthcare services, at the healthcare service providers, and at the women themselves, and see the needs of each of these groups and implement an optimal screening program so that it works. Thank you.
Thank you, Rena. Thank you so much. I think I'm just going to open this up now for any questions, or also, how in your context you are able to increase screening of perinatal mental health disorders. Please, Erica, I see your hand.
And first, that was a good presentation for Mijke. Is that right? Am I saying right? Mijke and Rena, thanks. And I was thinking about our reality here in Brazil, and especially in São Paulo, in my university. And we don't have a national policy for that. We start to think for perinatal mental health issues, but here we implemented that in we had an outpatient service from our breastfeeding center, and we started screening since 1920. And Rena, we found exactly same resistance, but feeling, not so good feeling from our staff. They all say that we know that is important. We know that we have to look for that, but we don't feel prepared. And if we don't feel prepared, we would prefer don't ask. Or if we do a screen, they just write us, the psychologist, okay, we do have a woman here with that screen. We are going to send to her. And now we start to work with that stuff and say, okay, that's not only the psychologist problem or issue, but for all of us. Then we start to ask them why they don't feel prepared. What is prepared? Is the communication? Is the feeling that when they don't feel, they don't know what to say. They are afraid to say wrong things and do the things worse. So it's so good to listen to you and say that we have same problems.
I think, yeah. So I think what we found really in the training to really work, do role plays and whatever, the big problem is that you train these screeners and then they leave the job, and then you have new people coming in. So these trainings have to be long lasting, and we really have to think of how to do it in a way that won't take so much from the trainers, because if someone comes in and they're working for a year, then you don't want to spend 6 months training them. You want to have a short training that will be effective. And what we found also, apart from the training, in places that we have some places that we have social workers who sit next to the nurses. And when they had like once a month, like a group together to discuss. So nurses brought up, various women with issues and whatever. That and then the social workers were there also, and they had like a discussion, case study discussion. So that really helped the nurses feel more confident in doing it. So it could also be a training. Let's say in Israel we have like a 2-day training, and it doesn't always happen. They do 2-day training once a couple of years, but it has to be like ongoing. And then if you have like these supervision sessions, like even once a month or something, that's something that could be very helpful. So.
Yeah, at our
Thank you.
hospital, we also have a multidisciplinary team that's gathering every week. And when healthcare providers want to introduce a specific case or patient, then we jointly discuss. And this is also learning by doing. So if they get more familiar with the process, then it's more likely to being implemented as well. So supervision is very important indeed. And regarding the training, we work with actors. So the midwives and other healthcare providers can try to use different strategies and see what works and what doesn't work. And these trainings are also highly valued because of their practical entrance.
I think please, Claire.
What do we know about reach of some of these? Firstly, thank you, Mijke and Rena. Really interesting lessons, actually. But yeah, I'm just wondering what we know about reach and equity of access for some of the more, I don't know if we're allowed to use the word marginalised now, but whatever word we would use for, you know, particular groups in the population that are maybe more hard to reach. Because Rena touched on this, right, when she talked a bit about cultural competencies of providers and that potential mismatch between providers and recipients. But yeah, I'm just interested in that, and I guess what we know from your different interventions about that.
What I could say in Israel, we have the Arab population who are a minority. They're 20% of Israel. So we have Arab nurses working with Arab women, and actually the acceptability is higher within the Arab population, and the Arab nurses felt more prepared than the Jewish nurses. That was interesting, actually. But that's also, it shows they feel, you know, I think that they stay more on the job. So they were trained and they stayed for a longer time. So they felt maybe more competent. But that's one group that we know. You know, you have various marginalized groups, and it's difficult, you know, to find the exact, you know, in the Arab population. So we could put, you know, Arab nurses who work in that population. But when you have other very small marginalized population, you don't always have someone from the same background working there. Mm-hmm. And I think, yeah, and that's a big problem. And what we find is that's part of the training, and part of the training is also cultural competence. But we didn't check with each and every, you know, marginalized population in Israel. We didn't get to that yet, you know. But from what we did do already, so we found that, you know, if you have people from the same background, that works. But what happens when you don't? And again, we're talking about the issue here is that they feel competent to do immunizations and to do other things. And the women also feel that those things are acceptable. But what happens when it comes to an emotional discussion? That's the issue. And I think more work has to be done on that for sure. Also here in Israel, we have to work more on that. But that's the big issue.
I think with both of your programs too, there's a lot of funding and a lot of infrastructure that has already been developed over a long period of time, right? So it's like 10 to 20 years to be able to do that. I'm wondering about your thoughts of places where there's not that funding and not that infrastructure, and how do you start that conversation and that process? And I, you know, really appreciated both of your presentations and thinking about different groups of people who need to be at the table, and how do you start to bring those folks to the table, and kind of your lessons learned from that, I think would be really helpful to hear.
in Rotterdam, we work a lot with focus groups where we invite the most vulnerable parents to discuss what their needs are. And what they say is that experiences from other parents in the same situation and in which help was successful is very helpful to inform these parents. So particularly when you do it in their own language, culturally adjusted.
And if the others want to talk first, and then I'll say, because we also have something in Israel that helped us get to where we are, but I see others raise their hands first, so I'll wait.
Yes, please. Calvin, I see your hand up.
Thank you. Good morning. Thank you for the presentation. It's very informative. I'm just curious about how fathers show up in the spaces where this work is undertaken. Thank you.
I think this is a very relevant question. And in the Netherlands, the difficulty is that the women are the patients. And as soon as you ask fathers for risk factors, and you need to refer, you don't have a medical relationship. So we are now working on like a standalone screen and advice tool that also partners can fill out and that they can be advised, and then they can, if they want, apply for additional support. But it's a difficult process.
I could say from our experience in Israel that this is on our agenda. Even we're opening a Marseille Society soon, and that's part of our agenda. But I think it took around 20 years to implement this program that we have, and it's going to take time. But fathers, it's what we call on the table now by us here in Israel, also working on that part. We do have studies that are coming up on fathers' mental health postpartum and importance of screening. So I think these things are going to help to work with that also. But the issue is also the same, like Mijke is saying, because the screening in Israel, we try to find a place where all women come postpartum. Now it's not only for women; men could come also. It's called mother and child clinics, but it's for immunizations for the baby. So any parent could come, or grandparent, or it doesn't matter what. But what happens, bottom line, is that mainly it's the moms that come, and that's why they are those who are screened. And we're trying to think of ways to increase the screening of fathers as well, and that's part of things that we're working on now. But if I could say, but I think, did Erica want to say something? Or I'll say a little bit of how we got even to have this universal screening in Israel. So in Israel, we have this group, with interest in the perinatal mental health period. So the group is comprised of professionals. So we have the psychiatrists and psychologists and social workers, and we have women. We have a couple of groups that represent women with lived experience. And we also have nurses and we have OBGYNs, and we have pediatricians in this group. And over the years, this is something that was worked on within this group. And also we were at the parliament, in Israel, it's called the Knesset, the parliament. We had several meetings there. We found people in parliament who had interest in this to help us move this forward. So there was a lot of work, and the person who's the head of this now, she's a communal, I always say she's a communal social worker. Now, community social workers, they work a lot with governments and with interest groups, and they know how to push these things forward. So you have to find someone who knows how to work with the government, who knows how to work with different groups, who could lead this group. And then on the group, you have to have researchers who could come and show, research findings, because the government is asking, okay, and also cost effectiveness. Okay, tell us how much is this going to save us if we do this prevention, or if we do this screening, or how much is this going to cost us? So you need people with research, with a research background, and you need people with clinical background, and all these people coming together with the same agenda. It was many years of working together until we got to this universal screening program. And still, it suffers from from problems, with having enough money to do different things and giving enough time for the nurses. We're not in the best place yet, but we're in a good place, better than many other countries I know.
Definitely a process. Yes, thank you. Other questions or thoughts of how you've done this in your own areas or thinking about this?
I guess one thing that I'll share is that a couple things. One is that we have used, I'm a sleep specialist, as I shared, a sleep scientist. And so we have used sleep-related or pregnancy-related sleep disturbance, let's say, as a less stigmatized inroads in which to target mood. So we know that restless leg syndrome, obstructive sleep apnea, and insomnia are three of the most common sleep-related disturbances that plague women anywhere from the first through the third trimester. And then when we look at OSA or sleep apnea and insomnia, can continue well into the postpartum. We also know that those sleep disturbances are highly linked to both anxiety and depression during the perinatal period. And so we've been able to utilize screening for sleep as a lever to get to the more stigmatized pieces around mood that we might otherwise have difficulty around. And with regard to fathers, one of the thoughts that I had, Calvin, I had actually two thoughts, is that I've been in two centers at which we've worked with fathers rather well. One was at UNC on the inpatient perinatal unit, where we had a clinical psychologist whose training had focused on couples therapy. And so he himself was not only male, which obviously gender concordance made a huge difference, right? A male speaking with other fathers, but also his research really focused on the role of the father in the family system through the perinatal transition, the peripartum specifically. And so he would meet with the fathers that would come to these units while someone like me was meeting with the mothers to provide additional psycho education. It was very non-stigmatized. Here's the big picture of what's going on in case you want additional information about how this affects your wife and family system. And through that, we were really able to provide some resources to the fathers that came that increased their engagement through the post-discharge period, right? They were more likely to attend session follow-ups. But when I think about why that worked, UNC is one of these unique institutions that have complete wraparound services. So I was a clinical psychologist that worked in some of the DBT full model groups or one-on-one with women therapeutically, and we were able to follow them from outpatient to inpatient hospitalizations, oftentimes with the same psychologist seeing them. And yes, Calvin, that research is available. It's Matthew Cohen is the primary author on the couples work, and I'm happy to ping you with some of the other elements there. But if you were to just look up Cohen and UNC, I'll put it in the chat.
And UNC is the University of North Carolina.
Thank you. Sorry for that. But I'm just wondering, just as a point of learning here, have we been able to, and the other place where we engaged fathers was at Children's National, where the whole family system was seen at well child visits, similar to what Rena was mentioning around catching individuals in other contexts and settings where it's less stigmatized. It sounds as if your clinics that see families from 0 to 6 months of age are analogous.
4 to 6 years.
6 years. Wow, even better.
That's all the immunizations are done there. It's different than in the United States. It's done by pediatricians. In Israel, it's done in these clinics. All the healthcare.
Though it's like a medical home that they return to throughout this period, which I think I recently just read a few papers that suggested that when you do see the same nurse, they call it like, I don't know what they called it in this paper, whether it was upcycling or that these nurses would follow cohorts of patients from 0 to 1 year to 2 years to 3 years through the pediatrics practices. And the amount of information they were able to garner was so much larger that the socio-emotional outcomes of the kiddos changed in a positive direction. So I wonder, and I think it speaks directly to what you're saying, Rena, about building trust, right? And building that relationship such that individuals are able to disclose. I'm just really struck by the amount of lead time that it takes. And I really appreciate you both highlighting that to bring the individuals to the table and really build these infrastructures. And what I have noticed is that we often have a referral system already very well in place before any of this can take place. I wonder if that has been the case for you all as well.
Making sure, just following up on that, that once you screen, to know what to do with those who are screening at high risk or really need that follow-up services. That's part of that.
Yeah, that's a very important part. Also to know where to refer to. But the big problem is that women don't go to there. That's another issue. That's for another salon, not for now. But that's another issue. But I think the most important thing is, first of all, to know where to refer to, and also not to be, I always, my students at university, when I teach, so all my students who give birth, they know that they have to come to me and tell me about their experience with the screening program. Like each one had different experiences, and they're all social workers. They're all, by us, we have a bachelor's in social work, so they come to me for their master's. So they're all working as social workers already, and they have experience. And they say, so one even says, she was screened and the nurse said, oh, you have to go and get medication now, like immediately, and whatever, she scored a 13 or something, nurses have to know, where to refer to and how to refer. And yeah, but there are, in Israel, we have a good referral system to refer to, but many women don't turn to that. But
thank you. Mijke, do you have any final thoughts that you'd like to share?
No, I wanted to come back to my statement that I think we should not only include the psychiatric symptoms, but take a broader approach, because this is all interrelated. And what I showed, the accumulation of risk factors, is also very important.
Great. Thank you so much. We have like a minute left. I just want to be able to thank our two wonderful speakers, Mijke and Rena, for being able to share with us really your wonderful lessons learned and to be continued. I think this is a beginning conversation for that. We are, if you look up Marseille, we are one of the 6 there, and you're welcome to follow up with any of us and our speakers if you would like additional information. We're hoping to do another webinar or salon, hopefully in the spring, really focusing on examining some of the prevention services that may be available for perinatal mental health disorders. So again, thank you so much. Thank you, Kelsey, for being able to monitor for us. We will put the recording on the website for anyone who would like to have additional information. And we just appreciate your being able to be here. So thank you again. Take care. Bye-bye.
Thank you all.